Welcome, everybody, to the Friends of NPACE podcast. I am Terry Schmidt, the Executive Director of NPACE, and I'm a practicing family nurse practitioner. And I welcome you all back because I'm very excited and honored to introduce today's guest. He's a longstanding nurse podcaster himself, and he's an expert in our topic we're going to talk about today. He's an advocate for the specialized population of veterans and veterans health. So welcome, Dr. Ali Tayyeb. He's a United States Navy veteran, having served as Fleet Marine Force Corpsman with Naval Medical Center in San Diego, 1st Marine Division, and 3rd Marine Division. Dr. Tayyeb earned his bachelor's and master's degrees in nursing from California State University, Los Angeles, and his PhD from the University of San Diego. He's a speaker and a consultant. Dr. Tayyeb is the CEO and founder of RN Mentor Consulting and creator of the RN Mentor podcast, and they have fantastic episodes. I encourage everyone to go and listen. He also currently leads and elevates ambulatory care nursing at one of the nation's largest FQHCs and serves as chief research consultant for the Los Angeles County Departments of Military and Veterans Affairs, where he's going to be leading efforts in reducing veteran suicide for the County of Los Angeles in 2025. Dr. Tayyeb is also the advocacy lead for the American Nurses Association California's Veterans Health Campaign. Dr. Tayyeb holds faculty positions at multiple universities in Southern California, and he's a fellow of the American Academy of Nursing and serves on the Academy's Military and Veterans Health Expert Panel. And he's on the board of the Association of Military Veterans Nursing. Did I miss anything?
No, you're good. Thank you. That's a lot of stuff. So I try to shrink it down, but
no, it was fantastic, and it speaks to your expertise, and I think it highlights all the places we can be involved and should be involved as nurse leaders, and some of us aren't. So thank you for the call to action.
Yeah, absolutely. Thank you for having me. It's a pleasure to be here.
Yeah, welcome to season 2. You're in season 11 of your podcast.
I am in season 11, and the podcast started as sort of a class project. I needed my students to, I had a project in my nursing leadership course. I had my students reach out to nurse leaders. And when the pandemic happened, like nobody was returning emails, nobody was returning phone calls. Everybody kind of went into hiding. So I was like, I can probably record something. And it was really my wife's idea to create a podcast. I'm like, just let everybody listen to it. I'm like, I don't know anything about podcasting. Long story short, here we are, season 11, or going into season 11. Yeah. So excited about the podcast and some incredible guests. I need to have you on. I don't know why I haven't had you on yet, but you're definitely on the short list.
Oh, so thanks. You. Well, we'll do this now. I'm not sure what I talk about other than.
It's weird being on this side of the microphone, so.
I bet it is. Well, so one of my goals in season 2 is to really hear people's stories about how they came into the profession of nursing. It is wonderful how unique each of those are. Nobody came in the same way. So tell me how you came into the profession of nursing.
Yeah, thank you. This is actually a question I'm very familiar with. I do this with every guest I have on. So yeah, it's before I get into my story, but you're absolutely right. Nobody comes into the profession the same way. And surprisingly, very few of my guests have ever had said, yes, I'm going to be a nurse when I grow up. Most of the guests I've had on have been individuals who are well known in the community, experts in their field. And almost, I want to say probably a good 95% of them did not intend to be a nurse, but somehow kind of fell into it.
Interesting.
Same thing with me. I never wanted to be a nurse. That was not even on my radar. I started out my military career. I started out as a Navy corpsman. And for those of you who aren't Navy corpsmen are like medics, but they serve in the Navy and they serve with the Marine Corps. The Marine Corps has all their medical people come from the Navy side of the house. And so this kind of transition, when I was coming out of the Navy, I was going to be leaving, getting discharged, and I was looking around what to do. I want to become a PA. I knew a couple of really excellent PAs, and I was like, that's a good thing for me to get into. And came out of the military, and I think I should preface this with I went into the military because I did not see myself going into college. Did not do very well in high school. My high school was, here's your diploma, please don't come to graduation.
Oh,
So I was one of those students. I was like, not a problem. Thanks for the diploma. Uh, so I ended up when I left the Navy, I knew I was going back to school. So I ended up going back to school, and then at the time the PA program was a bachelor's degree program. I'm like
hmm
I could do a bachelor's degree program, and then at the time, within like months of me being back in school, the PA program turned into a master's program, and I said, "There's no way I'm doing a master's degree." So I'm like, "What else can I do?" And a friend of mine said, "Why don't you look into nursing?" I was like, "Well, I've worked with nurses, not really crazy about the idea of working with nurses." So, but I looked into it and I said, you know what? There's a lot of things I can do because my only experience with nursing was nurses tend to be in charge of corpsmen in the
Yes,
hospitals or in the field medical service areas. The only time like corpsmen are really have independence is when they're with frontline units where there's no nurses assigned. Then they have more independence. Uh, But if you're in the rear with any of the units that are sort of like hospital units, there's always a nurse that's probably in charge. So my experience was like, okay, I really don't want to do that kind of work. But when I looked into nursing, I saw there's so much diversity in the things that you can do, and there's so much flexibility. I'm like, well, I could probably do that. And I looked into it a little bit more, talked to a couple of people, and I said, okay, I'll do that. And that's how I ended up in the world of nursing, is really as a default because PA school when it became a master's degree, and I was like, I'm not doing that. So long story short, I chose nursing as my career path, and I've loved it ever since.
I love that story. So that's different than all of the other ones we've heard. I think we don't give enough credit for that process, right? So which is going to work best for me? What kind of fits where I want to be in college? And it's not
Yeah.
that people go in dreaming of being nurses and
Yeah.
serving that way.
It's perfectly fine. If you're like 5 years old and you want to be a nurse, I'm like, fantastic. That's your path. But I like the fact that other people trickle or find their way into nursing because, I teach in multiple different levels, so undergraduate to graduate to doctoral programs. And I love teaching our accelerated bachelor's programs or our entry level master's programs because there's so much richness that people bring in. And I encourage people, like, don't leave that stuff at the door when you enter the world of nursing. Bring all that stuff with you because that lived experience, that other way of thinking, the other information that people bring into the world of nursing, it just makes the profession that much richer,
I
right?
completely
Um,
agree. Yes.
so the fact that I sort of trickled my way later in life, I was 28 when I went to college because that's when I had left. I had served 10 years in the military. I was 28. Going back to college was intimidating to begin with, and hopefully we'll trickle into this topic because it
Yes.
is one of the issues with veterans who leave the military and go back to school. I was taking English 101 with a bunch of 17, 18-year olds. So uh, the experiences are just different. How you fit into a classroom is different. But luckily, I found my way through academia and actually did really well in my junior college when I attended. I got my AA degree because the college I was attending did not accept my application for their nursing program. I got waitlisted. Luckily, Cal State LA picked me up, and I was actually like graduate speaker for my college. One of my professors had nominated me to be the graduate speaker, which was very kind of her. But yeah, I think I did okay. I did okay. I turned out all right.
You did. It's interesting that you say don't leave who you are and what you've experienced at the door. I think it does feed the profession. It certainly has in your case. So I want to get a little bit into our population, but I want to ask about your military service first, what that was for you, what that meant, and how that fed your nursing career.
Yeah, great question. Um, it was so in high school I was part of the ROTC junior ROTC program. I've always been attracted to the military for whatever reason. Maybe it has to do with, well, I'm originally from Iran. That's where I was born, and my mom and I came over when I was like around 11, 12 years old. And I knew my uncles, my grandfather were in the military. You know, it's mandatory service in Iran for men. So I kind of saw that stuff around me, and I'm positive like that influenced me to some degree. I was also there when the Iran and Iraq war was happening, so I think that influenced some of this stuff, my sort of interest in the military. But when I came to the U.S., I was in a program in junior high school where it was called the California Cadet Corps, where we got to wear uniforms and do all that stuff. And so I was there, and I think part of it was because I had immigrated here. It was a way for me to fit in with a group of people. It was like a sort of a thing like that. Um, in high school, I joined the junior ROTC, and I did really well over there. I just had a niche for the military. So when my high school career was kind of coming to an end, I was like, what am I going to do? I had already been approached by recruiters, clearly, just because they're in every high school in LA. I had the opportunity to speak to him. I had actually one recruiter that pursued me like quite a bit, and so after him and I talked, I said, okay, like, yeah, let's join the Navy. So that's how I ended up in the Navy, and I already knew I wanted to do something medical for whatever reason. My mom was a radiological technician or technologist, and I think that probably influenced me looking at medical stuff. But I knew I wanted to do something medical. So I went there, and my ASVAB scores were really good. So he said, "You can do whatever you want." I'm like, "I want to be like a medic or corpsman or something." And he's all like, "Yeah, we have corpsmen." And he's all like, "Just an FYI, you might end up serving with the Marine Corps side of the house as well." I'm like, "That's cool." Um, and it was right before actually the first Gulf War. This is when I joined. It hadn't started yet, but my boot camp time was around this. Was actually the first Gulf War lasted just such a short period of time that I had signed up. I was waiting to go to boot camp. By the time I ended up in boot camp, the first Gulf War was over. So I ended up going into the military, and I wasn't like the best example. Boot camp I did fine. My first duty station at the Naval Medical Center in San Diego was quite interesting. It was my first time like away from home, really. Had my own apartment, had a car. Let's say as a like a 19-year-old with complete guards down, I didn't do that fantastically my first year in the Navy. So I ended up in front of the admiral because I got
Oh,
in trouble. Um, but that you need those lessons in life to sometimes set you straight. He was very generous with me, and he's all like, he's all like, I was in what we call it HN, a hospitalman. He's all like, HN Tayyeb, I just want you to know this is your first year in the military. This is not da da da. He gave me a whole spiel, and I respected him. And I'm like, all right, so that squared me away for the rest of my career. And I did really well in the military. So I continued to excel. But my 10-year mark kind of came about, and that's when I decided whether I was going to stay or leave. But that whole time in the military, all the experiences I had, really, all the deployments, having been responsible for my troops or my Marines when I was stationed with the Marine side of the house, the experiences I had really, all of it kind of set me up for success for when I was transitioning out. What the military unfortunately didn't do for me is really tell me what transition was going to be like when I left the military, which is a
Okay.
huge issue with our veteran community. That transition period is critical of whether you're going to make it or you're not going to make it. Hopefully, I
Interesting.
answered your question.
No, you did. And I think that's going to get into our discussion today. So I brought you in to really talk about this subspecialty of a population, which
Yeah.
I know I'm in primary care. I'm doing mostly telehealth, which means people who have no access anywhere else. We're often a last resort. They're rural. Um, their primary care retired, their insurance has too big a copay, or they're uninsured completely. I find that I have a good handful of veterans who just don't have access to a VA or are struggling in the care they can get. They're not
Mm.
understood, they're not heard, they have a unique set of problems. So really I brought you in to kind of talk a little bit. So help us understand who this population is of veterans who have served and why it matters to primary care clinicians.
Yeah, absolutely. So again, thank you for like highlighting this topic because I think it's so very much needed, especially in the nursing community. We do a lot of thank you for your service. This past Veterans Day, I saw every organization in nursing came out with like thank you for your service, all that stuff, which is fantastic to see, and I really appreciate it. Not to take away from that. However, when you look at the agendas of our nursing organizations, very seldom do you see the veteran population specifically pulled out and highlighted. So I kind of put everybody on notice. I said, I appreciate everybody's, I think it was on LinkedIn or something. I said, I appreciate everybody's thank you for your service. I hope you realize this coming year, 2025, I'm going to be knocking on all your doors so you can make the veterans community and our military community and our families of our military and veteran community a priority on your agenda. Because what I usually hear from a lot of nursing organizations is yes, but there's so many competing agendas, right? So it's just one of those things that kind of gets under my skin because I'm like, you make sure that you highlight Veterans Day, Memorial Day, all that stuff. But when it comes right down to it, it becomes another topic among a list of other topics that are the flavors of the month for you, which I don't really necessarily appreciate that. But we are seeing some movement, and it's really from the nursing veteran community that we are seeing some movements and some pushes. For example, the Western Institute of Nursing Research, which I'm going to highlight, was kind enough or had the foresight to actually we created the military veterans special interest group, which we just had our presentation approved for a symposium, which we'll be presenting in I think it's April is their 2025. So that's one group. We have like the American Academy of Nursing, which I have the pleasure of serving with some incredible colleagues that are part of the military veterans expert panel. And as of 2025, and this isn't out there yet, but I mentioned I sit on the board for the Association for Military Veteran Nursing. If you Google that right now, you're not going to get anything because we're not live yet. But we just got incorporated. It's being headed by Dr. Mona Pearl Treball from Columbia University. No. Um, University of Colorado. University of Colorado. Um, so we have colleagues from that expert panel that are putting that association together. So there's work being done there, which we are going to go live in 2025. So if you're a nurse practitioner out there and you serve with the veteran community actively or even passively, because I guarantee all your nurse practitioners at some point have had a patient who was a veteran. So everybody's welcome to join the organization. But that's another opportunity for us to highlight. And there's you see small corners of the world that are looking at it, but it's quite passive for right now. So we're trying to make the topic more active for as because it pertains to all of our nurses. But when we look at the population, right now we're sitting anywhere between 16 and a half to 18 million veterans, right?
Mm,
And this does not include our active duty. This does not include their families or any of that.
okay.
And our World War II veterans are very quickly on the decline, just because they're getting to that age. And if you always see them on the news, they're like 99, 100 years old, 105 years old. So the World War II veterans, unfortunately, we have pretty much lost that generation. Um, there's still some around, but those, I think at one point I was reading, we were losing something about 300 plus of them per day.
Mm,
So huge decline in that population. But the ones that we do have are our Korean War era, our Vietnam, our first Gulf War, and then the Persian Gulf stuff with Iraq and Afghanistan. And at any given time, we are, or veteran or military active duty military personnel are deployed probably anywhere between 40 and 70 locations across the world. So we're always on deployment. The reason why it's an important topic for our um, nursing community to be aware of and our nurse practitioners to be aware of, because as I mentioned, they are seeing this population because despite what most people tend to believe, that veterans get their care from the VA, the Veterans Administration, Health Administration. That's actually not the case. Most veterans are getting their care out in the community. Some less than half of the veteran community are getting some or all of their care within the VA system. So most of us are getting care outside in the civilian community. Think of the VA almost like the workman's comp of the military, even though they're not associated with each other. The two really have a hard time talking to each other. So, so the VA is really like things that are related to your military service, they'll take care of. So depending on like for example, the disability rating of the individual, anywhere from 0% to 100% disabled veterans, the VA will take care of whatever issues that were related to your military service. For our veterans that are 100% disability, the VA takes care of everything. But from a care perspective, most of our veterans are getting their care out in the community. So, like I said, most of your NPs, most of our nurses are taking care of a veteran. It's just a matter of whether they know it or not know it. And based on our assessments, we don't ask that critical question of "Have you ever served in the military?" Right? And even if I ask that question, "Have you ever served in the military?" would I know what to do with that information?
mm,
And the answer to that for most people is going to be no.
right.
So
Why is this population special? What do we need to know?
it's special because first of all, I mean, first and foremost, live in the U.S. We talk about our freedoms all the time, right? And these individuals are the ones that have actually volunteered, signed a dotted line, giving of themselves, knowing that they may be killed, knowing that they may be injured, knowing that they're going to be away from their friends, family, loved ones for months and years at a time. Um, for that sacrifice alone, as a country, we owe that to the veterans, right?
Agreed.
Um, back in the day, back in the colonial days and things like that, when people went out to war and came back, the community took care of them, right? If they were lost, the community took care of their family. Now the community is so much not there anymore, and everybody defaults to the federal government. Veterans don't come back, military service members don't come back to the federal government when they leave the military. They come back to the communities that they left.
Mm,
Um, So it's important for that community to have the knowledge and the experience to take them back in and help them reintegrate into the community. Because what the military does is enculturates you into military life. So people, and you have to think about when people go into the military. It's primarily in their late teens, early 20s, when they're still building their identity. So when they leave the military, having that new identity reinforced on a daily basis, when they come back into the civilian community, it's that transition period is extremely difficult because first of all, not only did they lose that culture that they were engaged with, but they also lost their norm, their colleagues, their family for all intents and purposes, right? They lost all that, and now they're into the civilian community where we are no longer I don't say no longer. We have difficulty reintegrating because we don't have the same commonality. We don't have the same values. We don't have the same culture, right? So that integration back into the civilian community it's extremely difficult for us, right? I've been out longer than I was in. I was in for 10 years. I've been out over 20 years. I know I don't look it, but but I still am actively transitioning back into the civilian community, right? Because my identity and everything I know was built for that 10-year period when I was in the military. So I am still quite awkward around civilians, and I have to keep in mind what I'm saying, how I'm saying it, the words that I'm using. And for those who know anybody who's a veteran or military, we have a very colorful language that we can't bring back into the civilian community with us, especially in professional settings. So sometimes I default, sometimes when I give presentations, I say, I was in the Navy for 10 years. If something slips out, I apologize ahead of time. So I should have said that before we started this podcast.
We should have done the disclaimer.
We should have disclaimer that something may slip out. That don't get offended. But not only that transition component of it, there's just so much that goes into it. One of the things our NPs and we'll just say nurses across the board don't know, and even our physicians and any other providers or healthcare professionals overall don't know about the service members or the fact that we have exposures, right, in our military service, whether it's psychological, whether it's physical, whether it's exposures to various toxic hazards. For those who serve, for example, in Vietnam, the Agent Orange. I'm sure everybody's heard of. Hopefully, everybody's heard of Agent Orange. Those were industrial strength pesticides that were used to clear out jungles. Unfortunately, we had a lot of our service members that were exposed to that, and not directly. I don't mean like they were sprayed on them or anything like that, which some of them were. But these were industrial strength pesticide, not the kind I use around your house or in a building, but these were specifically designed to kill vegetation in a war zone, right? But we have exposures of people who were in the area. We have service members that served on ships on the coast of like Vietnam and those areas that were exposed to it. We had people that were on planes that carried these barrels of pesticides that were exposed to it. We had people in the U.S. that worked in the storage facilities where these pesticides were created or stored. So we have millions of our veterans who had this kind of exposure, and those exposures lead to a slew of different kind of chronic conditions, cancers, and you name it. And it's not just them; it's also some of it has been passed on to their children, right? So there's those kinds of things. We have the first Gulf War, the second Gulf War, those kinds of things that we had exposures to all kinds of sarin nerve gas. The first Gulf War had exposures to sarin nerve gas. Some of the
fires, we had all of those.
All the fires, the smoke, the oil platforms that were unfair. So all kinds of respiratory issues came as a result of that. The burn pits. I'm sure people have heard of burn pits, but don't necessarily know what burn pits are. For us military folks, it's the burn pits are a norm or were a norm, and I think it still happens in some places, even though we know the issues. Is just we burn our trash, and trash is everything. We don't leave anything behind. Out in the middle of the desert, big giant holes in the ground. All the trash goes in there. That trash gets burned, and those are like plastics and clothing and just everything. And those had those exposures have created, that's the Agent Orange of the Gulf War, right? Is those burn pits, because we use so much of them and we put it around our troops and our troops breathe them in, and now we have all kinds of issues related to that. And as a result, the government passed regulations for the VA to actually actively start looking at benefits and treatments for those burn pit exposures. And President Biden himself, his son, he believed like his son's brain cancer was related to exposure to those burn pits. So there's dozens and dozens and dozens of diseases, chronic conditions related to individuals that have served in the military. Um, I'm sure people have seen commercials on the Camp Lejeune water stuff that, the water had some toxins leak into it, and there was issues around that. We've exposed our own service members to sort of chemical agents. Either we use chemical agents to protect, like for example, our vehicles and our clothing against chemical agents, but the chemical agents we use were more toxic than the chemical agents that we were being exposed to. So all kinds of health conditions are related to it. As somebody who doesn't know that, if I'm trying to um, treat an individual who comes in for anything, if I'm not properly screening them, I'm not going to catch anything early. I'm not going to know what the reason for those things are, and I won't have the ability to appropriately treat my patient, right? And this is in addition to all the cultural norms and things like that that goes into, or cultural sensitivity that goes into treating veterans. So there's mental health issues, physical issues, and the exposures that really, there's a huge gap of knowledge because we don't cover it in our programs. Very few programs actually have anything veterans related. Um, and I think probably a few years ago, I looked about 100 different programs, and only 5 of those programs actually had anything veteran related embedded into their curriculum. So huge gap in knowledge, but we have a huge population that needs to be appropriately screened, needs to be appropriately assessed, and even if I was somebody who was not a veteran and didn't know this stuff, I need to at least be able to ask some of the pertinent assessment questions, and I need to be able to direct that veteran to a resource, whether it's a county resource or the VA resource, or even if it's some of our veteran service organizations like the American Legions, VFWs, Veterans of Foreign Wars, the Marine Corps League, the Disabled Americans of Disabled American Veterans. So there's so many different organizations that have veteran service officers that can actually help guide that individual. So if we don't have those kinds of guidance or having that resource to be able to share with veterans, we won't be able to do a whole lot. And then on
Nope, I was
top
just
of
going to stop you because these are all fantastic. For our listeners who actually watch this, because sometimes we put it out in video on YouTube,
yeah.
but they know I take copious notes for my own practice. So I want to get to resources
Yes.
because you just gave us a great list. The assessment questions and screening. I feel like this area is almost like in primary care by gender and age. I have a screening list, right? I know who goes for a mammogram when, who goes for prostate or colon cancer, or what age we start looking at skin cancer. Is there a resource out there like that for clinicians with veterans? What age they are, where they served, what branch of the military they were?
Yes and no.
Okay.
So the American Academy of Nursing right now, they're in the process of revising it. But there is a Have You Ever Served campaign from the American
Okay.
Academy of Nursing,
Okay.
which is a list of questionnaires, starting with the first questions, have you ever served in the military? And then it goes through some questions. However, that questionnaire is the very start, right? The VA has a similar
Right.
thing,
Okay.
and they have a questionnaire that's available to the community. Um, the problem with the questionnaires is unless somebody's going to actively search and look at other resources, right? So if I get a yes or no through that questionnaire, I go through and it's an algorithm type, and what do I do with that information, right?
Right.
I
Right.
document it, but then what do I do with it? So if I haven't actively looked at or sat in on some kind of a continuing education or actively looked for my community resources, those lists aren't going to do a whole lot for you,
Okay.
other than helping you, at least at the minimum, identify that the individual is a veteran.
Okay.
The reason I say that's an important thing within its by itself,
Agreed.
because if we look at, we're not even asking that question. So the first step is like for us to ask that question, and then people, as either if they're individuals or as organizations, need to also ask, what do I do with this information? What do I want to do? And it shouldn't be just the fact that I'm collecting the information. I need to be active and do something with it. That's
Right.
important when we're looking at screening for any kind of chronic conditions or things anticipating. If I know a veteran has been exposed to burn pits, I should keep, even if they may not be exhibiting any kind of signs and symptoms for anything other than they're here for their yearly checkup, I need to make sure that they understand that they need to go and get screened by the VA, or at least we need to keep a close eye on a slew of things that could happen down the line, right?
Okay.
Um,
Agreed.
in addition to that, from a mental health perspective, we need to make sure we're regularly screening our veterans. Veterans have the highest rates of suicide out of any population, right? So for them to get, and we know from when we look at the data, most veterans that are committing suicide are not in the VA system. So
Gosh, no resources then.
So the VA is really good about making sure that they tap you on the shoulder every time you come in and they do a quick screening for specifically that, making sure that you're good to go, you have what you need, and you're not at risk, right? We don't do that with our veterans outside of that community, right? One of the things that we see is because the VA does um, sends because they don't have enough resources for veterans to begin with. So sometimes some of our veterans are seeking, the VA is paying for it, but their healthcare providers are outside in the community. But those healthcare providers don't know the veteran system either, right? Or the veteran culture. So we also see some suicide rates for the people that are getting care. They're getting care in the civilian community, but it's by individuals that aren't familiar with the VA system or the veteran culture, right? So it's important for our healthcare providers to understand that they need to become um, competent and proficient in the care of veterans because they are seeing them out in the community. So making sure that we are at least assessing them because things can happen at various stages of life. And I talk about transition being difficult. We lose a lot of veterans in that first year or two outside the military because they have failed to transition back into the community. And as said, these are our 20-year-olds, right? 20-year-olds, 30-year-olds. They're young individuals that just failed to transition back into the civilian community. They hit hard times for various reasons: drug, alcohol abuse, access to firearms. Um, those kind of things play in, and unfortunately, we lose them. We also see we also see that we lose veterans later in life because they start losing their supportive community, the other
Mhm.
veterans, their friends, and they lose that social network that they have built. So we see veterans also committing suicide later in life. And good number of tricklings in between. But unless I am, so it happens at different stages of life. So it's not just one point in time that I need to do that check-in. It's multiple. At every opportunity that we have, we need to be checking in, making sure that that veteran continues to thrive in the community. And if there's any kind of issues, concerns, that those are addressed, whether it's through the VA system, through a community resource, through a county resource, because they're available. It's just a matter of the fact that, do our healthcare providers know that resource exists? And can they refer that veteran, do a warm handoff, right? To and not just give a veteran a number. Here, call this number, hopefully you'll get in, right? But do a warm handoff, which we wish we could do with every service, but do that warm handoff to a service that you know is going to take them in and make sure that they are getting the resources that they need.
I'm taking copious notes. I don't think that last part can be emphasized enough. We are so used to, in this mass of patients and in the organized healthcare that we have, just writing a referral, and sending a number and a name, and you call them. But that warm handoff for this particular population for mental health is almost like calling the ER when you're sending a patient that's at high risk. Really can't be emphasized enough that that's important.
And there are resources. There are resources within a lot, I won't say a lot. Some cities and counties have like a Veterans Peer Access Network, which LA County has, where it's trained peers that can connect with that veteran and help them guide them through services or seeing what they need or whatever the case may be. Texas has a very active group. I know LA County has one, and there's other ones within the US that exist. Those veteran peers are critical to the success of some of these programs. So
how do we find those types of programs, veterans peers programs?
Either it's usually ran by either the state or the county that you're in. So most counties or cities have some kind of a veterans office separate from the VA. If they can't find that within their city or county, because I know not everybody lives in a big city or county, just reaching out to their local veteran service organizations like the American Legions, the Veterans of Foreign Wars,
or the DAV, or
the DAV, so there's a number of them they can reach out to and see if there's anything like that within their county, and if not, what other veteran resources are within the county. That's one of the things. Not everything is available, standardized across the board. So people have to do a little bit of legwork, which is one of the reasons, I started the consulting company, is just really to make sure that we are providing a resource. So people who are interested in creating that veterans component within their organization, but they don't have necessarily the expertise or the resources around it. Like how do we combine those two so you can help them strategize moving forward and creating that veteran-centric level of care that our veterans need. Because unfortunately, in the nursing world, it's just we haven't tapped this population up.
Which surprises me, because we have so many nurses who have served.
Yes, we do. We have a lot of nurses and people who are in the military with other whether they were nurses in the military or they served in other avenues and came into the military or came into the civilian world and became a nurse. And I'm hoping this is what the Association for Military Veterans Nursing will do, is help solidify this community and putting out some incredible individuals that I get to have the opportunity to work with to help put this information out and create this organization, which again will go live in 2025. So fingers crossed. There is enough interest and there's a lot of interest. It's just a matter of, like I said, so many organizations have these competing priorities.
No, I agree. I'm writing down so much. So we have to have you back because I know we're going to run out of time and your time is precious. I appreciate you sharing it with us. Because we need to talk about this call to action,
Yes.
particularly in the NP and in the larger healthcare organizations themselves. We have all of these offices and smaller groups to help support patients in certain subsets, and this has been lacking. It's time. There's
Yeah.
not enough resources. So I hear you say ask. So primary care clinicians, we have got to ask about military service.
Yes.
We have to make an effort to know our own resources. So just like ordering a lab test, you got to know what you're going to do with any answer you get out of that.
Yes.
So finding community resources in the county or the state, the office, and then these other local organizations, becoming experts. And I think expert is I'm going to use that term a little subjectively, but knowing veteran culture at least, or being
Yes.
aware of it,
Yes.
is critical for all healthcare providers.
Absolutely. And the
Because
VA, yeah,
go ahead.
sorry, but the VA is a great resource as well. I don't want to,
Okay.
there's resources
Yes.
for providers within the VA website. It's free. All you have to go is look for it. Just look like veterans health conditions or veterans um, yeah. Just look in
Definitely
the
will do that.
VA system, and I'm happy to, if there's a way for you to share a specific link, I'm happy to
Yes.
look that up and share that with you.
Sure.
Whether
We will
you,
post those. Send us
yeah,
some
yeah,
links.
yeah,
Okay.
definitely. Yeah, I'm happy to share those with you because the VA has done an excellent job when we talk about PTSD, TBI, mental health conditions, all the different exposures that have been recorded and what kind of conditions they can lead to. Based on where the time frame that people serve, based on where they served, all of this stuff like the has been brought out. So yeah, things like the PACT Act, and how veterans can benefit from the PACT Act, and that's the toxic exposures bill that just got signed a couple of years ago by President Biden. So these are all opportunities for our nurses to learn, and I highly encourage if any all the organizations out there to make it a point to have at least one of their sessions be around a veterans topic when they have their conferences or symposiums or what have you, because again, making because it's such a niche community, having to compete with all the other things out there. A lot of times the veterans topics get pushed aside because they're like, oh, we covered it last year. But there's so many topics that need to be covered and it's not covered anywhere else. Yeah,
We'll be reaching out to you for those hints.
awesome.
And I agree, because it's a whole, they're just such individualized health topics that we need to be
Yeah,
talking about and
yeah.
screening.
And it sounds specialty. It is a sound specialty.
Definitely. Two things we didn't really have time to get to today, so I guess I will run a teaser for the audience that I want to talk about with you in the future is more digging into the mental health and suicide risk,
Mm,
especially as you dig into what you're going to do for 2025. For
absolutely.
LA County, we're trying to address those issues more, particularly in mental health and suicide risk. So I do want to talk about that. And you've worked with even a specialized subpopulation of veterans, and those are veterans who've been dishonorably discharged, who don't have
Yes.
access to the same resources, no matter how long they served. Or,
Right.
yeah. So
Yeah.
that's a
So
whole
yeah,
nother topic.
that's a whole nother time, but that was my entire dissertation. So that
Great.
that would take its own session. So yeah, there's a lot to be unpacked there.
Okay. Well, NPACE part 2 and 3. We will do suicide risk and mental health. But I do want to talk about veterans who've been dishonorably discharged. I think it is worth the topic and the bandwidth. So,
Yeah, absolutely. Yeah, yeah. So just real quick, just to touch on that, not all veterans are able to access VA care or VA benefits. So, and based on, it's not always characterization of discharge. Sometimes it's based on how long they have served. Even some of the way some of our National Guards and reservists who haven't actually done any active duty time, and they've only done the 1 week in the month, 2 weeks out of the year. Many of them have not been able to access VA care because the VA doesn't recognize them as veterans, even though they have served 20, 30 years as a reservist.
And
So,
could be called up at any
and
time
could
for
be
anything.
called up at any time, but they haven't been. But they've done 20 or 30 years of reserve service, so a lot of them haven't been able to access benefits. So that's a whole nother thing. But there are five characterization of discharge, and only an honorable discharge is able to access all their benefits. Anything below that, an administrative discharge, and other than honorable, a bad conduct or dishonorable discharge, pretty much it starts taking away things like education benefits, job training, housing, healthcare, burial, all the other benefits that our veterans are entitled to and have earned. These are earned benefits. I want to emphasize that. Because some people, lately with the new administration coming in, we've heard these things about veterans are receiving too much. So these are earned benefits for their service. So being able to access them, and the whole idea of having benefits is to help veterans transition back into the civilian community. That was the whole premise behind it, but it's to ensure that our veterans are able to access their earned benefits.
Agreed. I like that word, earned, and they certainly did. Dr. Tayyeb, thank you for being here, for your
Absolutely.
service, and for
Thank you.
being a
Thank you.
nurse. We're
Thank you.
glad
Thank
you
you.
found your way here. And we will post all of this so our audience can find. So to everyone who's listening, you can find our podcast on YouTube, on Spotify, on Apple Podcasts, and we'll post all of this there and any links that you can send for us. We really appreciate your time. NPACE is an ANCC accredited provider of continuing education. We're also in 2025 working with AAPA on select events to provide CME education to other advanced practice providers. So we're trying to reach everybody. Any parting words before we go, Dr. Tayyeb?
I want to thank you for having me on. That's first and foremost, and bringing attention to this to our veteran community. I'm if you weren't able to hear it in my voice, I'm super passionate about making sure that our veterans are successful in their transition and they thrive in the civilian communities they come back to. So anything we can do to help make that transition easier, making sure that we're providing the appropriate level of care and service, and us being proficient and competent in what we do, I think is important. So thank you for anybody who is listening. And just listening is great. There are some just really quick. I'm going to put out there some webinars already on ANA California's Veterans Health campaign that we did last year. That's available, and they're CE accredited as well. So if you're interested, just to get an intro into some of the topics like our veterans families, LGBTQ community, an intro into what veterans are, those types of topics are already in there and awaiting your attention. So thank you.
I appreciate that. We will definitely do that. I appreciate you holding us accountable, and we hope you continue to do so with what we're doing here at NPACE. People can find you also at the RN Mentor podcast and listen to your other nursing work there. Thank you for teaching us today, as well as the students. For everyone listening, for the Friends of NPACE podcast, we're going to sign off. Thank you for being with us.
Thank you.